Good afternoon, everyone. I think we give ourselves probably like one so that we give others a chance to join before we begin. We could begin. So my name is Dr. Daniel Maina. I'm a pathologist based at Lekaka University Hospital here in Nairobi. So I am the moderator for today's session. So if I can briefly introduce Dr. Pujo. Dr. Pujo is a consultant in chemical pathology at Royal London NHS Foundation Trust, based at the Barnet Hospital site. She qualified in medicine from University College London Medical School, and following her MRCP, specialized in clinical biochemistry at the Royal Free London at the UCLH. She obtained her FRC path in 2006. Her specialist interest is lipid disorders, and she does lipid clinics. She also has a special interest in medical education and teaching, and is an undergraduate tutor. So Dr. Pujo, these are chemical pathologists and laboratorians from 3 African countries, that is Nigeria, Kenya, and Ghana. The floor is yours. So please lead us in the discussion today. Over to you, Dr. Pujo.
Thank you, Dr. Maina. Thank you. So this case is very clinical, but I'm going to concentrate more on the laboratory aspects of this clinical case. So the clinical part is interesting, and there's a lot to discuss about the clinical situation of this case as well. But we're going to focus this on the laboratory aspects and the liaison between a laboratory and a hospital clinician, okay, or even a GP, a primary care clinician. So next slide, please. So we're going to go through the case like a proper clinical case, okay. So around September, one of these years, a 59-year-old patient was referred to the emergency department by the patient's GP because routine primary care bloods were reported as lipemic. No biochemistry could be reported on this sample, and the clinical details, the reason why the GP had requested this was medication monitoring. So the biomedical scientists in the biochemistry labs, they have a list of analytes with critical phoning limits. So anything that's very high or very low, that's been decided with the clinicians needs to be phoned out. The biomedical scientists in the lab would phone it out. So the biomedical scientists actually informed the biochemistry consultant who was on call and asked whether they could add on lipids, because lipids was not requested on this sample. Lipids were added on. Next slide, please. There were abnormalities found, and the GP referred the results were phoned to the GP, and the GP, that's general practitioner, referred the patient to come to the emergency department. Okay, so the patient came to the emergency department, and this is his history. His presenting complaint was generalized fatigue and leg cramps, but otherwise felt well. And I think they had also written abnormal blood test results. His past medical history included type 2 diabetes, diagnosed age 33, for which he had been commenced on a basal bolus insulin regime. He had hypertension, chronic kidney disease, and he'd had an NSTEMI in 2015, requiring multiple stents. He was on long-term anticoagulation also for a left ventricular mural thrombus, and he was on prophylactic antibiotic cotrimoxazole after a graft rejection from an abdominal aortic aneurysm repair. Social history: he had a raised body mass index of 34.6, and he admitted to having an erratic diet following a recent bereavement. He was a current smoker with 120 pack year history and did not drink any alcohol. His family history: both of his paternal grandparents had cardiovascular disease. His paternal grandmother also had diabetes, but it was type 1. Next slide, please. So one of the investigation that was really abnormal that had been phoned to the GP was his triglyceride result, which was 160 millimoles per liter, which is, I don't know what units. Do you, is everybody familiar with millimoles per liter units for triglycerides?
Yes.
Yeah,
Yeah,
yes, we
yeah,
are familiar.
yeah, great. So
Yes,
that is
yes.
obviously incredibly high, very, very high. So there's a dilemma, we have this sample, it's extremely lipemic. Our normal, analyzers, they're just saying, sorry, can't analyze. In your labs, what do you do in this situation? If anybody can just put their hand up and answer, what do you do in your, the clinician is saying to you, I want a result, I want to know this, I want to know that, I want the amylase, I want the creatinine. What do you do in your lab? Any answers? Anybody are willing to have a stab at this? Nope. Okay, we'll move to the next slide then. Yep. So what we have in our lab, and different labs differ. We have a process called ultracentrifugation. We have the ability to do that. And after ultracentrifugation, we can normally, get quite a lot of the results that can't be analyzed initially. So you can see from here, and of course, sodium we is a special case. We don't analyze the sodium and potassium after ultracentrifugation because they're done in a different way. But most of the other analytes like amylase, we can. So this you may not have heard, but I asked the question, and if anybody could put their hand up, in your lab, if you receive a sample with a very, very high lipemic index, how would you normally approach it? And anybody can put their hand up. Okay, so there's something in the chat. Okay, no, okay. So in our lab, we do ultracentrifugation. We ultracentrifuge a sample, and we can analyze most things. Sodium and potassium cannot be measured after ultracentrifugation. They're measured in a different way. And I'll talk about that way later on in the presentation. But the rest of the analytes, you'll notice this patient had a raised creatinine of 148, normal ALT, alkaline phosphatase was raised, albumin was normal, corrected calcium was normal, and the CRP was slightly raised, and the amylase was in the normal range. Okay, so those were the results that we could give the clinicians on that first sample. So moving forward to the next slide. This is what happened. So this is a real case. The patient declined formal admission against medical advice. As a result, I think they spoke to myself, and I said to give him Omacor tablets. Does anybody know what Omacor is? Yep. These are special prescribed fish oil capsules, and they're approved by the National Institute of Clinical Excellence for hypertriglyceridemia, and they reduce VLDL synthesis, thereby reducing triglycerides. And so this was my tablet of choice, because the other tablet of choice that I could have given is contraindicated if the patient's got renal failure. And in this patient, their creatinine was high, 148, and there was an element of kidney disease. And this was the progress. So initially, you noticed he came on the 4th of September, then he refused admission, and he was made an appointment for this. We have a service in the UK called ambulatory emergency care, which is in between the emergency department and outpatient. So patients can be given an appointment to be seen urgently, and these are these patients who are kind of unstable and need to be followed up quite quickly. So he had been given an appointment in this interim emergency care unit for the 7th of September, and DNA stands for he did not attend that. Then on the 11th September afternoon, he came to the emergency department himself, booked in. When they called him, he didn't answer his name. So he just had bloods and he left. So you can see he's quite a difficult patient who's not, that engaged, at all. But he had bloods done, again showing triglycerides of 162, which isn't surprising because he really hasn't had treatment, or we haven't even found out the causes of his high triglyceride. 11th September evening, he came in. I think he was called by the medical team on call and refused admission, but he was given the Omicor at that time. And again, ambulatory emergency care appointment follow-up was made because he didn't want to stay in the hospital as an inpatient. So a few days later, he actually did come to the ambulatory emergency care department, and repeat bloods were done. The triglycerides were still very high, 172. And this time they could investigate for the causes of it. And one of the causes of very high triglycerides is uncontrolled diabetes or newly diagnosed diabetes. And his glucose, that was 27, which is millimoles per liter, which is incredibly high. So again, he left, and then he came back to the emergency department about more than a week, I think about a week later, and he finally agreed to be admitted to the hospital for treatment. Next slide, please. On admission, his physical examination was unremarkable. His blood pressure was slightly high, 150/90. He was tachycardic with a heart rate of 105 beats per minute. His respiratory rate was normal at 16, and his oxygen saturations on room air were normal at 96%. His abdomen was soft and non-tender, and that's very important. Why is it very important that his abdomen was soft and non-tender? Does anybody know why we're checking for that? Elikem, yes?
Yes, I think we worried about acute pancreatitis and then subsequent peritonitis.
Exactly, yes. So they're trying to exclude by examination any signs of pancreatitis, which can be caused by very high triglycerides. There was no lipid stigmata xanthoma or xanthelasma. Next slide, please. They repeated all his blood tests. His triglycerides were 137. Total cholesterol in this situation is irrelevant. We're not managing it. It's not reliable. All we're doing is looking at the triglycerides. That's the most relevant, clinically relevant parameter. Admission glucose was 14, and he had some ketones, and he was acidotic. So he had a normal Allen gap metabolic acidosis. Amylase was within the normal range, and the other blood results of that sample could not be done because it was too lipemic. Next slide, please. So he was transferred to a monitored bed and commenced on fixed rate insulin infusion. This was later increased slightly by a few units. And then they tinkered with his insulin, increasing his levemir, and his triglycerides and usinase were monitored daily, and he would seem to respond well to treatment. There was close observation of his renal function, and if required, we would ultracentrifuge his samples daily till the triglycerides came down to such a level that the sample was no longer requiring ultracentrifugation. Venous blood gases were performed daily in order to get accurate electrolyte values. What's the most important electrolyte value that we're looking at here on the blood gases? What do we need to watch? Is it on insulin? What do we need to watch? What electrolyte do we need to monitor?
The potassium.
Sorry? Yes,
Potassium.
Why? Exactly, potassium. And potassium, exactly. Why is that? Why do we need to monitor potassium?
But because the patient can be treated into having hypokalemia.
Yes, because of the insulin, it takes the potassium. So we need to.
Insulin moves potassium into the cells.
Yes.
So,
Yes, Exactly. Thank you.
Yes.
Yes. So, so they were monitoring that closely, uh, and they were also observing for acute complications of so they were observing to see if he did develop pancreatitis, and whether he developed any sort of stroke or cardiovascular heart type symptoms as well, because they can get heart attacks, strokes as well as pancreatitis. Not acutely, but in the long run, this is the risk. Next slide, please. So you can see how his triglycerides started coming down after treatment. So it started off at 132, 137, and then after he started the insulin, they came down to 96. Quite a good reduction in quite a short period of time. These are daily blood tests. So that is a very, very good reduction. And the triglycerides are millimoles per liter. My sincerest apologies for not putting that unit there, but they're in millimoles per liter, these values. Next slide, please. So as a patient was somebody who wasn't really, that inclined on engaging, he self-discharged himself before completing his treatment. His triglyceride level at the time of discharge was around 57. Fortunately, at that time, he was well supported in the community by his general practitioner, who contacted the patient on a weekly basis following self-discharge and updated the hospital team on his progress. And the GP managed his triglycerides in the community by increasing the doses of his subcut insulin injections. In particular, his Levemir was gradually increased to 60 units once a day. Next slide, please. So 28 September, he self-discharged, now under the care of the GP. Whilst he was an inpatient, a blood sample had been taken to look for any genetic or lipoprotein lipase deficiency, as levels of triglycerides that high could indicate some underlying genetic condition predisposing to very high triglycerides. And such conditions are things like lipoprotein lipase deficiency or ApoC2 deficiency. Next slide, please. 1 month after his self-discharge from hospital, he reported feeling much better. His leg cramps had resolved, and his exercise tolerance had returned to baseline. Most recent blood tests revealed a single-figure triglyceride of 8 millimoles per liter, and an HbA1c which his initial HbA1c had been 149, which is incredibly high, and it had come down to 60. Next slide, please. Okay, so we'll stop there. If you go back to the previous slide. So if we have a quick discussion about this case, from the laboratory point of view, the sodium, what happens to sodium in a lipemic sample?
There's a pseudo-hyponatremia from
Yes.
following electrolyte exclusion effects.
Yes, it is called a pseudo-hyponatremia. So this patient's sodium had initially been low before, and that was likely due to a pseudo-hyponatremia. And so how do you get an accurate sodium measurement in a patient with who's got very high triglycerides in hospital setting?
So analyze the sample using iron selective electrodes.
Direct
Yes.
iron selective.
Yes, so
Direct
sorry, I missed that. Just say it again.
direct
again.
iron selective electrode.
Yes, correct. So we measure it using direct, yeah. And which type of analyzer uses the direct ISE technology? Which analyzer in the laboratory or in the hospital uses this technology?
Blood gas analyzers.
Yeah, correct. So if you have a blood gas analyzer in A&E or even in the lab, you'd measure the sodium in these kind of patients, using a blood gas analyzer, because you do not get the pseudo hyponatremia effect if you use the direct ISC technology for measuring sodium, which is what is used in the blood gas analyzers. Okay, so if you go on to the next slide, this is a different case. And this case illustrates, the clinical needs and a dilemma. So 31-year-old, 29 weeks pregnant, known type 2 diabetic and hypertensive, urine 2 plus protein on dipstick. Next slide, please. The triglycerides were 26, and we were unable to report the liver enzymes, and the sample was lipemic. Now, in this case, why are the clinicians so hell-bent on wanting the liver enzyme result? Go back to the previous slide, please, and look at the clinical scenario. What do you think why do you think they wanted? What are they thinking of? What diagnosis? What diagnosis do you think they're thinking of?
Possibility of a HELP syndrome from preeclampsia.
Yeah,
Preeclampsia.
preeclampsia. Yeah, preeclampsia. So this case illustrates that sometimes there are, if you go on to the next slide, there are certain clinical situations where it is really important to try and give results to the clinicians. So in this case, because we had ultracentrifugation, we could ultracentrifuge and give the liver enzyme results to the clinician. Next slide, please. Right, this is another example. This is a 38-year-old gentleman who presented tired, and his sodium is low. Sodium of 129 is low because our reference range is 135 to 145 millimoles per liter. Potassium is 4.1, which is normal. Normal range is up to about 5, I think 3.5 to 5. I'm just saying roughly, can vary between labs, obviously. Urea is slightly high from our lab, 8.5 millimoles per liter. The creatinine is raised, 169 micromoles per liter. Hemoglobin is low, 9.6. The white blood cell count is 7.6, which is in the normal range, and the platelets are in the normal range. So this patient has got a low sodium, and low sodium is one of the most common abnormalities we see in the hospital. Where I work, there's lots of elderly patients. We've got a huge inpatient population. What are the causes of low sodium? So this patient is not elderly, but what are the causes generally of low sodium? How do you approach that? Any takers? How would you approach the investigation of hyponatremia?
First, you
First,
confirm
you assess the plasma osmolality.
Yes. And if I told you that the plasma osmolality in this patient was normal, then what would you do?
If it was normal, then I would exclude the possibility of a pseudo hyponatremia from either hyperproteinemia or hyperlipidemia.
Excellent, thank you. Next slide, please. Exactly right. This is a different example of pseudohyponatremia compared to the previous case. This is a very, very high total protein of 149, and the blood gas measurement of sodium was completely normal, 142 millimoles per liter. And so we did protein electrophoresis to find out what the protein abnormality was, and there was a large paraprotein band of 76 grams per liter in the gamma globulin region with marked immune paresis on the electrophoretic strip. Immunofixation confirmed the presence of a monoclonal band type IgG kappa. So this is a case of myeloma. Next slide, please. So these are the take-home messages. Know what lipemia means. We come across a lot of, junior doctors or nurses, other staff who see these results being reported on the computer systems as lipemic. Often they do not know what that means, and they don't add on lipids, and the whole fact that the patient has got, very high triglycerides is completely missed, and it's a clinical risk. So they don't know, what it means. If lipids are not ordered, we normally ask the lab to add these on. And to be aware of what your local lab can offer to give you the other biochemistry results when a sample is lipemic. Be aware of pseudohypernatremia, how to identify it and the causes of it. Be aware of the causes of high triglycerides. And involve the medical, endocrine, and lab teams in care if not already involved. So, for example, a patient with high triglycerides will need care from the lab, from the endocrine team, and from the acute medical team as well. And sometimes if they've got pancreatitis, they may be also partially under the surgeons. Whereas a patient with pseudohypernatremia due to high total protein would be under the care of the hematology team if they had a paraprotein, which is usually the cause, for such high total protein as in this case. So looking at this, it's not only a question of us lab professionals being aware of all these points, but it is also our good practice for us to teach these points to our junior doctors, our fellow consultant colleagues, registrars, etc., so that they can analyze and they can interpret these things. Not analyze, they can interpret things appropriately themselves. I recently came across a case in my lab with a clear pseudohypernatremia, not this case, a different one. And in the clinical notes, it said, didn't say pseudohyper, it said low sodium due to dehydration. Clearly, that was not the case. It was due to pseudohypernatremia. And so not only should we have the knowledge ourselves within the laboratory environment, but it's very good to educate the clinicians so that they do not misinterpret results. So I'm just going to have a gap here before I go on to the other bit of the presentation. So far, does anybody have any questions about this, what we've talked about so far? And also, I'd like to get some ideas, and if you could share with us what mitigation you have, how you go give clinicians results when a sample is very lipemic. I'm just looking in the chat.
So, Dr. Kujo, there was one question about what levels to check out for in terms of triglycerides that then put one at risk for pancreatitis.
Well, actually, sometimes even 10. It depends. This patient did not have pancreatitis at levels of 160 millimoles per liter triglyceride, whereas another patient may get pancreatitis at 20. So there's no predictor of who's going to get pancreatitis. We don't know, but it does vary. Some patients can get pancreatitis even if their triglycerides are 10 millimoles per liter. So there's no way that you can predict who is going to get pancreatitis, but you just know the higher, the more risk.
Okay, great. So the second question on the chart is refers to I think the first case that you presented.
Okay.
So the question is why the HDL could not be detected because
yes.
the triglycerides were more than 13.6
well, they were 160. They were 160. The sample was like cream. Nothing could be measured. It was spectral interference. HDL could not be quantitated. Nothing could be. All we managed to get is a triglyceride result. And at that level, we don't need an HDL. An HDL is not something that's going to clinically help us in any way. For this patient, knowing what the HDL was would in no way help us manage this patient. And it could not be quantitated because the triglycerides were far too high and it was extremely opaque and white looking, the sample.
Okay, yeah, I think those are the only two questions on the chat, but the participants, please keep posting your answers or questions or any comments on the wall. do you look at them
Yeah.
in the Q&A
So
session?
there is another way. So we do ultracentrifugation, which is one of the gold standard ways of processing these kind of samples. But there are other kits that you can get. One of them is called LipoClear, and there's like protocols on how you can use them, to mitigate for the high triglycerides. And in some labs in the UK, they use kits like that. Okay, next slide, please. Right. So let's go back. Sorry, quickly. Yeah. So we're going to talk about the causes of high triglycerides, and I have given you an example of a couple of patients with diabetes. One very, very uncontrolled diabetes with an HbA1c of 149. What are the other contributory factors, causative factors of high triglycerides? When you see this patient in A&E or somebody asks you for your advice, what other things would you ask them to try and measure? What are the secondary causes of hypertriglyceridemia apart from uncontrolled diabetes? So thyroid function tests, okay, because hypothyroidism can be a cause of a secondary cause of hyperlipidemia. High body mass index. This patient had a high body mass index. Excess alcohol intake. And nephrotic syndrome. So we should always do a urine dipstick or a urine protein in patients with hyperlipidemia to exclude nephrotic syndrome as a secondary cause of hyperlipidemia. Liver disease or renal disease can also cause high triglycerides. And certain drugs like estrogen-related drugs, oral contraceptive pill and tamoxifen, protease inhibitors such as ritonavir. Okay. Right. Next slide, please. So that's the summary of some of the possible causes. Then apart from these causes, there are some genetic causes. And the next slide alludes to those. If we go on to the next slide, please. So there is a condition called type 3 hyperlipidemia. In this condition, usually the cholesterol and triglycerides are about the same. And on agarose gel electrophoresis, and I will show you some of those strips towards the end, you get a broad beta band, which occurs in about 2/3 of plasma containing floating beta. And there's another genetic condition, hyperchylomicronemia, where if you stand the plasma still, a cream layer develops over a clear infiltrate, and that's a diagnostic test for whether a sample contains lots of chylomicrons. Then there is another condition called familial combined hyperlipidemia, where a clue is that the apolipoprotein B, which is a protein associated with LDL, is high. And then you get a condition called familial hypertriglyceridemia. I am not going to go into the details of any of these genetic conditions. They're complex. So if anybody's interested, they can read up more about the genetic conditions causing high triglycerides. But these are the sort of things that, the more commoner ones. Next slide, please. So now, clinical signs of hyperlipidemia. What clinical signs of hyperlipidemia does one look for on examination? What are some clinical signs of hyperlipidemia? Does anybody know? On examination of a patient?
Yes, we have the corneal arcus.
Yes, corneal arcus, but what age? What age? There's an age cutoff, isn't there? If you have a corneal arcus in an 85-year-old, it would not be considered significant because
individual less than 40 years.
Yes, when they're young. So corneal arcus when they're young, like less than 40. Any other signs?
Tendons and tumors.
Yes. Anything else? No? Next slide, please. What about this? What's this called?
Lipemia retinalis.
Yeah, this patient we should have looked at the patient that I presented with 160. I bet you he had lipemia retinalis, but it's not easy. Not everybody's not pulmonologist, and there's not always, in a busy A&E to kind of search for this. But this is called lipemia retinalis. The veins are, they're completely, everything's white. Next slide, please. That is called eruptive xanthoma, those spots. And that can be seen in these kind of conditions in type 3 hyperlipidemia as well. Next slide. Xanthelasma, fatty lumps around the eyes. Next slide, please. This condition is pathognomonic, so very specific to type 3 hyperlipidemia. And if you look at the palmar creases, they're orange, and they're called palmar xanthoma. So this patient that I presented did not have it, but in a patient with very high triglycerides whom you suspect may have type 3 hyperlipidemia, always look at their palms to see if they've got these very bright yellow, it's very obvious, palmar creases. Next slide, please. Those are tendon xanthoma. Next slide, please. Right. So I was talking about type 3 hyperlipidemia, and I'm going to show you what they mean by floating beta. So here, lane 16 contains neat serum sample. Lane 17 is supernatant, showing VLDL, and lane 18 is infranatant, showing LDL and HDL. Okay, so in lane 16, the top, the first band that you see is HDL, and the middle is VLDL, and the last is LDL. The sample is prepared by normal centrifuging, and then serum is diluted and then sample ultracentrifuge. The supernatant is number 17 after that process, and the infranatant is number 18 after that process. Next slide, please. Now you will see here that there is an overlap. There is an overlap between the trailing edge of lane 5 and the leading edge of lane 6. And that is called the broad beta or floating beta. And so we send samples to we have a specialist lipid laboratory, which does this for patients that we request it on. And it's only usually the lipid specialist that requests this. And they look at the strips and they tell us if the patient's is positive or negative for floating beta. Next slide, please. Yeah. So this is a bit of an explanation about pseudo hyponatremia. Has anybody got not feel shy to kind of take me through why pseudo hyponatremia occurs? Does anybody want to a couple of you want to discuss how does it actually work? Why is it occurring? So what happens, what happens after you dilute the sample? So in a sample with high total protein or high lipids, you get an increase solid phase particles, okay? And so you have less of the water phase and more of the solid phase. So if you dilute it, it creates a sort of error, and you get a over diluted sample, and you get a falsely low sodium. Right. So that is the end of my slides. And I was hoping that we could have a bit of a discussion around what happens in your laboratories, and share a bit of practice as to how you, if any of you have come across these conditions, and how you go past pseudo hypertension and what your practices are. It would be really useful, for me working in the UK, to know how it is in other countries. So, I keep asking how you deal with lipemic samples. Do you see lipemic samples quite a lot, or is that something that's quite rare in your laboratories? Please feel free to speak up.
Well, thank you for the lecture. I wanted to say that my name is Akim Lawa,
Yes.
and I was a bit astonished or shocked with the level of triglycerides that you reported, 14,000 something
That was
milligrams
in
per
the,
day.
yeah. I tried to convert it into milligrams per deciliter as well.
Yeah, so
Okay,
that's what we are
yeah.
familiar with over here. And I think for my 6 to how many years of practice,
Yeah.
I've never. I was beginning to think maybe what method was able to pick so much of triglycerides. Is it something maybe down here? I'm in Nigeria, practicing Abuja. I don't know whether the methods we're using, and in my laboratory we use Roche systems, Roche
Yeah,
Cobas.
yes, we do that as well. We use Roche. Yep.
We've never picked higher. We've not picked higher than 500 milligrams per day. So seeing 14,000, I was like, is this academic? But anyway, I just wanted to say, is it something normal in your area where you see 10,000?
Well, yeah, not normal. I wouldn't say it's normal, but we do have a deprived population. So we do have quite a lot of disengagement with the medical services, perhaps. That we have, some patients who drink quite a lot, because it's deprived. There's more sort of obesity, you know, high alcohol intake, smoking can also cause high triglycerides, and because there's less access, or they engage less with they can come up with these badly controlled diabetes, uncontrolled diabetes, and this is a classic example where you saw that the patient was just refusing to be treated. He has actually passed away now. That was a few years ago that I came across him. He was also found to have be heterozygous for the lipoprotein lipase deficient enzyme, and not being properly controlled diabetic. That whole mixture of different factors made his triglycerides become that high. We have a procedure in our lab that initially, when they measure, the triglyceride comes up with a strange error or some sort of, I'm not that technical, but it comes up with a indication that there's something wrong with this patient's triglycerides. And our biomedical scientists have a SOP and a little cue card where they have to dilute the sample and then rerun it till we get a result. So our population is such that it is a partly deprived area. So we do see a lot of patients with clinical conditions which cause high triglycerides.
So, secondly, let me just quickly round this.
Yeah.
Because of costs, we use the Fredworth formula. We tell patients to fast. Then we use Fredworth formula to obtain, to calculate LDL cholesterol. So maybe, I don't know, maybe that is why we're not catching, because we're telling patients to fast. Maybe that's why we're not catching so much high triglycerides.
This patient, even if they fasted, the triglyceride is going to be sky high because they have that secondary cause, uncontrolled diabetes. Fasting, non-fasting, this triglyceride on this patient, there's no way that a fasting sample on this patient would have been normal because they have that underlying uncontrolled diabetes. So we use Friedwald's for equation as well. But yeah, we normally ask if there's a triglyceride problem. We normally ask for a fasting sample. But in this case, I think it's extremely abnormal to have a post-meal triglyceride of 160, and it needs to be treated, and the underlying cause looked into.
All right, thank you very much.
Thank you for asking that.
Okoli, if you have any challenges, you can also post your question. You can type it in the chat box, and then you read it.
I'd be really interested to see how you deal with lipemic samples in your lab. Do you have any of these kits or some, what mechanisms you have for giving results in lipemic samples?
As you've put it, I think it's a challenge in this part of the world to basically treat lipemic sample so that you can actually come up with accurate results. First, most of us don't have the ultra centrifuges.
Right,
so
right.
Yeah, we do not have that. We also don't have specific kits that can do that.
Yes, yes.
So sometimes we try to use the normal centrifuges, but at higher G levels.
Okay, okay.
Yeah, just to try and see if that could help. But again,
Right,
I do agree with you that even where we practice here, like for instance in Kenya, some of these very abnormal triglycerides we see are actually due to secondary causes, and most of them would be uncontrolled diabetes.
Yes,
Yeah,
and once you control that, then things start getting better.
Yep. Okay, but it would be good to hear also from other labs how exactly they do handle an IP example, because it's a challenge, because the first thing that the lab techs tell you is that this sample is very unique. What do you do about it?
Yes, yes.
Yeah, I mean, that's the first thing they ask you.
And sometimes we get clinicians calling us, in the lab saying, I don't care what the result is, just give me the number, But you have to explain to them it's not an accurate number that you're giving, without ultracentrifugation, which is slightly more accurate, obviously. But they said, no, because we don't provide ultracentrifugation out of hours or at the weekends. We only provide it during working hours. So, if we get a sample at the weekend, it'll have to wait till Monday. And, sometimes we have to argue our case, do clinical reasoning with them to manage it clinically. And sometimes by the Monday, they've treated the patient with insulin or something, and the sample is clear and they can measure things, so that it doesn't need ultracentrifugation anyway. That's what happens in my experience. And do you have these specialist lipid investigations, like floating beta and things, access to
again,
any?
Again, if I could talk where I practice.
Yes.
We don't have that available, so we've not basically invested in lipoprotein electrophoresis. So
yes.
But I know that there are some labs where they're actually able to do the lipoprotein electrophoresis.
Yes. Yeah. And in fact, I wanted to share with you, we sometimes have patients with Waldenstrom's macroglobulinemia, which is a kind of hematological myeloma type condition with such high plasma viscosity due to total protein that we can't measure even the total protein, because the serum is like a gel, it's not liquid. So in those cases, we usually tell the hematologist that it's likely to be something like that, and they measure, if they can, plasma viscosity, and then I think they treat them first till they can, because in those samples we can measure absolutely nothing, because the sample's not even liquid. Even if we do give a result, we're not sure how completely accurate that is. Right, so okay. Shall we finish it there? Oh, I've got a question here. Does storage has effect on lipid assay results? Storage meaning, no, we just store the samples as per the, what it says on our, kit insert. So storage, there's no particular storage requirements for serum on which lipids are done. It's quite it's quite stable. It's not like plasma metanephrines, which the samples have to be bought immediately and frozen. It doesn't really have much of an effect. We only keep samples usually for a week, and then we discard them. Shall we leave it at that?
I don't know, anyone, but yeah. So I think there's the question that has or a comment rather. Can you give specifications of your ultracentrifuge? that you use at the kits, we could use alternatively to handle lipemic samples. If I got you right.
So I haven't got it myself because it's done in our central laboratory. We're a hub and spoke module, so it's done by our central laboratory, and I haven't got the technical specifications at all. But certainly I can speak with our lab to find out if they're willing to share it. Okay, but I'm sure you can. I'm sure you can do a bit of a research, on Google or on your usual sort of biochemistry websites where you procure things, and have a look for to see if there's an ultracentrifuge available. But I haven't got all the details. We have a whole SOP on it.
Yeah,
and I guess if you're not seeing many of these kind of samples, then there would be no point in you having an ultracentrifuge because most of the time it would lie unused. But we actually get samples sent from other hospitals sometimes as well. Local hospitals who don't have an ultracentrifuge, they can also, send us samples as well sometimes. Yeah.
Probably just touch on the indications for lipoprotein electrophoresis. So when would you perform a lipoprotein electrophoresis?
Yeah, so that would be for floating beta only. Yeah. And really only for floating beta. We do agrogel. We don't really use it for anything else. I guess you could use it if somebody had a very high HDL, and you could, if you wanted to confirm that, you could either measure apolipoprotein A in serum, or you could do lipoprotein electrophoresis just to confirm that they have a high HDL. But there's no other reason that I can think of that we would use it clinically, lipoprotein electrophoresis.
All right, great. Basically, Dr. Pujo, I think those are quite interesting cases, and these are practical cases. Touching on some of the pre-analytical challenges that we encounter in the lab. These might look obvious because it's a lipemic sample, but I'm sure that there are many other pre-analytical challenges that we are not able to pick visually. I'm also aware that
because everything's automated, Dr. Mena.
Yes.
We don't look at samples now.
Yes.
In the old days, we used to actually look at the samples after spinning them to see if it was lipemic, enteric, whatever. Now everything goes automated onto the thing, and we only pick them up, if the analyzer, indicates.
Yeah. The HIL indices. Yeah. So I think I think that is also one area that probably we're very good at because it's now become automated. But again, also the issue about the interpretation of the HIL indices and the potential for interferences. Again, that is not something that most of the times we concentrate on, but it would also be good probably just to also emphasize the need to basically look at what the equipment is reporting in terms of the HIL indices and the interference, because as you rightly put it, the interference could be, from different angles. Yeah, spectral interference. It could be epidemiology. Yeah. So I think it's important that we are aware of the pre-analytical issues that can actually then result in spurious lab results, and probably then take the appropriate actions, or as you've put it, discuss with the clinicians, tell them what it is the lab is able to do and what the lab is not able to do. Sometimes I know that for some results we do give a caveat and tell them that this result may be unreliable. The sample was glycemic, and as you put it, probably a few days later, the sample now gets clear, and you cannot get the actual, you cannot get the accurate results by thermometer. So I think it's a question of being aware of what some of these pre-analytical factors are, and also then having this discussion with the clinicians, because working in a low resource setting, we may not always be able to treat most of our samples to basically get an ideal sample. So thank you very much.